My name is Tamara Knotts. I'm a dually licensed clinician, LCSW LAC, work for Montana Primary Care Association. And I'm the IBH Special Projects Director, and the bulk of our work focuses on integrating behavioral health, substance use disorders, medication for opioid use disorder work, and co-occurring disorders. So our plates are full. We are slated to do an hour and a half for you tonight, and we have so much packed, just jam packed into this. So what I'd like to do is probably maybe save questions for the end, and then we actually are going to show a video. We could have a few questions after the video as well. So yeah, and Mandy, I'm assuming that you can help keep an eye on the chat box.
Absolutely.
And Gina maybe too. Okay, yeah, between Gina and I. So Gina and I are primarily doing this presentation, and then Dr. Knotts is along for the ride to answer any questions that may come. So Gina, do you want to do a quick intro of your beautiful self?
Well, this beautiful self does work for Montana Primary Care Association. I've spent most of my career in the mental health, behavioral health, substance use disorder world. And then about 6 years ago, came into the medical field to integrate those services, and love what I do. Glad you guys care and are here today. That's all.
Thanks, Gina. Dan?
Yeah, I'm Dan Knotts. I'm a board certified internist and addiction medicine specialist. I am an independent contractor with the Montana Primary Care Association, and in that role, I provide trainings for providers to obtain their X waivers. We also, with the change in the rules as far as getting X waiver, we also provide a shorter course called MOUD Boot Camp, which is primarily for persons who've gotten their X waiver by what's called notification of intent, where they do not have to do the either 8 or 24-hour training. I provide support to federally qualified health centers, tribal health programs, critical access hospitals, and we're currently involved in a statewide program to promote the implementation of medication for opioid use disorder in emergency departments.
Thanks, Dan.
I'll leave it at that.
All right, thanks. Yeah. Okay, so we are in our planning time. We determined that we're going to do provide information on language and stigma and what happens in healthcare, and then do some education on medications for opioid use disorder. Now, if there's other questions, if we leave you hungry and wanting more, which I'm sure we will, please let Mandy know, because we can come back again. We've got, gosh, so many topics, but we really want to get to the mission at hand. So MPCA is, we're the primary care association for the state of Montana, and primary care associations just give a lot of support to federally qualified healthcare centers, our urban Indian centers. And with this grant that we're working under, we really help any healthcare center with anything and everything IBH. MPCA's vision is health equity for all Montanans. So Gina and I have done an awful lot of training together. We have traveled the state far and wide, and we really appreciate that, you know, different groups of people and different sites are at very different levels of knowledge. And you know, regarding awareness of stigmas, our own stigma, our cultural stigma, et cetera. So one of the things that we like for you to keep in mind is that we're not trying to talk you into or persuade you to feel sorry for patients with substance use disorders. That's not what we're trying to do, but we are trying to grow compassion and awareness, and really further the understanding that these sorts of disorders are chronic illnesses that involve the brain and brain chemistry. We also know that healthcare workers on the front line, working with this population, which is really highly acute, can lead to a lot of burnout for frontline healthcare staff. And it's rare that feedback comes. So it's with this spirit that we deliver this training. And what we know is that stigma, which leads to discrimination, really is the crux of the matter when it comes to increasing access and providing services to those folks with substance use disorders. So Gina's going to take just a second and get us here.
Yeah, let's just take a quick minute and just drop everything that we were doing before we came together today. And if you could just kind of leave it at the door, as they say, if there's something that you need to pick up before you leave, certainly know that you can set it down for a while and then pick it up and take it with you if you need to carry it with you after the training today. So let's just take a minute and just kind of get into our bodies. And I'm just going to ask you to close your eyes if you're comfortable closing your eyes. Some people are not, and if you're not, just gazing downward, and then taking your right hand and just placing your right hand on your forehead, placing the palm of your hand on your forehead, and then taking the palm of your hand and placing it at the back of your neck. And then let's take about 3 breaths. So making sure we're inhaling and then exhaling about twice as long as we inhale. So inhale and then exhale. And again, inhale and exhaling, just making that exhalation longer. And one last time, inhale and exhale. And then leaving your left hand at the base of the skull, take your right hand and place it on your heart, just in the center of your chest, and do the same. Just take 3 nice deep breaths. Yes, just lovely. Again. And one more time, maybe feeling the gravity of Earth as you do this last exhalation. Good, and then leave that right hand on the center of your chest, and then take your left hand and bring it down and just place it just above your navel. Just in that, it's connecting the heart and the digestion. And again, about 3 breaths. And as you are exhaling this time, just notice the pull of gravity. Just pulling you into the earth as you let go. Bringing yourself fully and completely into your seat, into the room, and onto the earth. All right, thank you very much. You can open your eyes now. So at this point in time, usually what Tamara and I do is we do an exercise that demonstrates how many of us have cared deeply for someone who has a substance use disorder, but we're not in person. So instead, I would just like to have you bring to mind someone. Most of us have someone that we've loved, we've cared for, whether it be personally or professionally. And just bring their spirit in with you today. You can even write their name down if you want, that would be nice. All right, so it's a lot. When we do this in person, I would say 99% of the people demonstrate that they have loved someone deeply. And that's no surprise because drug and alcohol use disorders are untreated. In 2021, over 107,000 individuals, souls died of drug poisonings. Only 6.5% of the 41.1 million people with a substance use disorder received treatment, the necessary treatment. That's it from 2002. So what I want you to do is imagine the outrage, right? If only 10% of people that had suffered from a heart attack received access to evidence-based care. We would truly be outraged, right? So what we ask is, why? Why aren't we outraged? And we've come up with stigma, which we're going to talk about a lot today. So right now in the good old United States of America, there is roughly one US drug poisoning death every 5 minutes. And so we've been at this for nearly 15 minutes. So 3 people have died just since you guys got on. Thank you, Tamara.
Thanks, Gina. So it all starts with stereotypes, and stereotypes are widely held but fixed and very oversimplified images or ideas that can lead to biases. So on this slide, there's listed a few pretty common ones that we have here in the United States. I'm skinny, so I must be anorexic. I'm young, so I must be naive. I'm a dancer, so I must be a show-off. I'm blonde, so I must be stupid. I'm a person, so I must be stereotyped. What other kind of stereotypes come to mind? You can just unmute or pop it in the chat. No others. Okay, I'm moving on because I'll give you a few more. So where that goes is it leads to explicit bias. So explicit bias are, there we go, conscious. We talk about it. It's something that we have learned from our environment when we're really, really young. It can result in microaggressions. There are things that I believe it, I say it out loud, and I know it's a fact. So an example of this might be that Gina and I we kind of suffered with in our childhood, was that redheads have tempers, or crackheads, just load them up and, take them out somewhere and shoot them. I mean, that's some explicit bias. And those are the things that we deal with often in our culture. So that then also leads to implicit bias. So this is something that develops very early in life from repeated social stereotypes. It could be either exposure or, people in our environment kind of teaching us different ways to think about things. It occurs without conscious awareness, and it's often in conflict with our personal beliefs. And even though we might reject these images, they still stick with us. And one of the things that is, not kind of fair about implicit bias is that they actually never go away. But the important thing for anyone, and especially healthcare providers, is for us to become aware of what they are, our internal and implicit biases that can result in external manifestations, and keep them in check. So one of my biases that came to light happened when I was working for Western Montana Mental Health Center. And one of my first kind of bigger projects was getting the women's program back in line and kind of up and going again. So I was working with women, most of which carried a co-occurring disorder diagnosis. And they were living at the Carol Graham home, women and children's home, and some were pregnant, some had kids. It was a very exciting time. And I noticed after a short period of time that I felt a lot of anger toward a few of my clients that were pregnant, and I couldn't figure it out because I was there to help and I really cared about my clients, and it was really kind of confusing. So I approached my supervisor, who was very good, thank goodness, and he helped me to sort this out and understand that this was an implicit bias, that I really had some internal judgment about women who continued using substances even though they were pregnant. So thank goodness I was able to work through that. And what we know, and had I not done that, it would have severely and negatively impacted our relationship. So we know that implicit biases affect our provider relationships. Our patients can sense biases from healthcare providers, either verbally or non-verbally. You know, about 55% of our communication is non-verbal. About 38% is intonation, and about 6% is the actual words. Another interesting point is that the third point is that provider biases may tell them that patients don't have the needed health literacy to engage in their healthcare, and this limits referrals to specialists. And I have seen this manifest in different ways. So we talk about what is it that we need in order to have a more accurate and a more effective relationship with our patients. It's all about trust, respect, and accuracy. So Gina, you want to do your accuracy thing?
Oh.
I love how you tell this.
You always catch me off base. So one of the things that we're going to talk about later is how we can manage our implicit biases, because they are so horribly dangerous, you guys, because they are unconscious. And so I was teaching for the first time about language and bias and stigma. And we had a special person that we paid a whole lot of money to come in, who was kind of an expert. And so I was talking about using certain language so that our patients could be honest with us. And so the presenter that was there, we were playing a game, so she raised her hand and she said, she said, I want to call you on this. She said, when you use the word honest, it insinuates that they are probably going to be dishonest with you. And so she was right. And so we kind of tried to start using accuracy instead of how accurate are they, instead of how honest are they. That's my story, my embarrassing story.
That's great, though. It really is a very, very good point. So our lived experiences can give us blind spots for sure and help us not understand or recognize our patient vulnerabilities. So when our stereotypes and biases are not addressed, it can lead to stigma, which leads to discrimination, and holy smoke. We know that discrimination withholds treatment, it withholds medication, housing, the ability to get a job, and to get insurance. You know, Gina also shares a story about 20 plus years ago. She had a female patient who was diagnosed with an alcohol use disorder, and her insurance company dropped her, would not cover her anymore. So it's how it was in the old days. It's not like that now, thank goodness, due to mental health parity, but that's kind of where we came from. So when we look at the different kinds of stigma, it comes in many forms: stereotyping, actual discrimination, social exclusion, power, labeling, so many different ways. And sometimes it can be hard to spot. So our social stigma, it manifests simply as disapproval of a person because they don't fit the required social norms that are given in society. And this is not just, social stigma does not just apply to those with substance use disorders. We see this everywhere, all the time, within communities, within states, etc. The next kind of stigma that we look at regarding specifically SUD is family stigma. Gina?
Yeah, and so we put this thing here of a beautiful boy. I don't know if anybody has seen this movie or not, or read the book, but I was just so lucky. I mean, it was pure luck that I was at a conference where David Sheff and his son were at the conference, and they stayed afterwards and talked to us and answered questions and talked about the family stigma. And I think because we live in Montana, right, and we know that there are certain families in our communities that they walk in and to see us And here we hear their name and we put them in a box. So we put them in the stereotype box, which is often a box that is stigmatizing as well. David Sheff talks about he was blamed. He was called names. He was called a codependent. He was called an enabler. He was called all kinds of names. And he said, all I knew was that my son was dying and I didn't want him to die. So he said, I was trying to do everything I could to keep him alive. He said, there's nothing wrong with that. If my child had cancer, no one would treat me that way, right? If I was in there saying, my son has cancer, please, can you help us? They wouldn't call me an enabler and shame me and ask me about my family history. The shame of substance use disorders and the stigma starts in early childhood. I would say by the time a child, and some of you may have grown up in homes where there was substance use, but that stigma starts early and they start to internalize it early, like we must be different, people treat us differently. They go to school and they learn about those people, those drug addicts, and the DARE program, call the police, and they're scared because their mother, their father, whoever it is, their sibling struggles with this illness, and they know they're sick, but that other people want to hurt them and maybe take them away. So the answer to this is education and creating a safe environment wherever you work, wherever you end up working, by signage, by using language that says, we know, we want you here, you are welcome. So that's one of the stigmas.
Thanks.
Yeah.
Go ahead.
No, you can go ahead. That's fine.
Okay, so the justice system, there's a lot of work being done in Montana to work with the different areas of criminal justice, so pre-release, detention centers, et cetera. In that system, there tends to be a more rigid black and white way of thinking and applying interventions. And basically it's, the bottom line for our Department of Corrections is public safety. But there is a lot of work being done with allowing and getting medications for opioid use disorders within those systems, as well as the full complement of psychotropics that are needed. And then in the healthcare system, what we see is providers or those in healthcare, clinicians, I mean, you name it, whoever's in healthcare, really do view patients differently, because this is what we were treated, this is what we were trained to do. We have lower expectations because we believe that there is a sense of control or fault with a person who may have a substance use disorder, and that it's about willpower. Just pull yourself up by your bootstraps and get moving forward. So because of this, our patients are suffering in the shadows, for sure. So this information is something that is very beneficial for an entire healthcare system to be trained on. With self-stigma, this is one of the most, it just really is one of the most malignant triggers that we have in the stigma world. There is so much guilt and shame with folks who have a substance use disorder, either about themselves, what they did to themselves, or what they did to other people in their world. They really don't understand the disease. They don't understand why they've done the things that they've done. And the stigma has been internalized. And so it really decreases their interest in seeking help. It negatively impacts their recovery because it decreases their self-worth and their self-esteem. And we're going to be showing a video later today that demonstrates that. But how the process of self-stigma goes is becoming aware that society thinks that people who use drugs are bad or drink too much are bad. And then they get to a place of agreeing and saying, oh, they're right. They are bad. Those people are bad. Boy, they're causing a lot of pain. And then they apply it to themselves and say, well, I have this condition, so I must be a bad person or a bad mother. And then you see that internalized decrease in self-esteem and self-efficacy. And they're left thinking, why in the world do I even try? So when we look at the special population of pre and perinatal patients, they have an even more complex stigma with healthcare providers, general public, loved ones, themselves, the addiction community. And when they're looking at, from the mother's perception, at preconception, the messages that they get are, you shouldn't have a baby. And then during that prenatal period, the messages they get are, you are hurting your baby. And then after delivery, the messages they're getting is, you can't care for your baby. So any way they look at it, it's a no-win situation. And even within our 12-step support communities, recovery support communities, there's still a lot of stigma around medications for opioid use disorder. A lot of discussion about tapering off buprenorphine with providers and counselors because somebody's not fully abstinent or they're using it as a crutch. So what's interesting, there was a study done, the Recovery Research Institute looked at 12-step mutual help organizations and how they are viewing and what's happening in those groups with patients who are on medications for opioid use disorder in terms of any negative attitudes and outcomes. And what they found was that there were 4 ways that negative attitudes toward those patients were enacted. And the first is by, within that group, prohibiting people that are using medications from speaking in meetings. So within their own support group, they are not allowed to speak in meetings in some places. The second is to really encourage people to shorten the length of time that they're taking their medications, which is not such a cool thing because they're like practicing medicine. The third thing they found is they will refuse to describe people who are on a medication for opioid use disorder as not in recovery. And the fourth thing that they saw is that there was a refusal to sponsor or act as a recovery mentor, people utilizing MOUD or prohibiting somebody from that's using medications from being a sponsor. So a lot of misinformation is out there, and how these patients responded is, number one, they just got angry. Second option, they left the group, they found a new group, or they started a new group. Third is they did not disclose their use in meetings, or they would only tell their sponsor, which, according to the tables, you're as sick as your secret. So that's probably not a good option. They tried to employ cognitive strategies so that it can minimize the importance of what folks are saying so that they can stay active in the group. And the fifth set of folks just said, oh, forget this because I'm talking about it anyway. This is what's real and true for me, and I'm here for my recovery. So to wrap it up, stigma is shaped by our thinking. It's a bias and perception that substance users are bad and immoral rather than ill with a chronic condition. It is communicated by tone, our interpersonal attitude, and our language, body language. It's communicated by words, and it becomes internalized by the person seeking help. And they absolutely view themselves as bad or wrong. So while I get our video set up for us, are there any questions or comments? Okay, hearing none, I am getting ready to share our video. This is called, this is Ending the Stigma of Opioid Use Disorder. It was originally intended for emergency departments, but I think it does a really great job at demonstrating stigma. So I want you guys to just keep an eye out and see where you can see stigma with healthcare, self, social, family, etc. Okay, here we go.
So I remember I was in an emergency room one time because I was desperately trying to get off of opioids, and I put my hand out to shake the attending's hand, and he really didn't want to shake my hand, and it was pretty clear. And that just killed me because I internalized that as I'm the drug addict and he's not shaking my hand because he thinks I'm dirty. And that was the message that was sent to me.
I did check in, and I was forced to answer all sorts of questions about what were these bruises on my arm, what was all this, why, and sort of this, why have you done this to yourself? Look at what you've done to yourself.
I had an infection that led to endocarditis, which is an infection on my heart valve, and I required heart surgery. He said, well, this is the only surgery you're gonna get. Are you gonna use again? And I said, oh, no, I'm not, I'm done. And I felt like I had to kind of pass a test in order for him to say whether or not he was gonna do this. And I could have been hooked up to a lie detector test. I was telling the truth. There was no way I was going to use again ever. But I did. I used 5.5 weeks after that. And after I woke up after a 10-day coma, I asked to speak to him so I could apologize to him. I said I was so sorry for messing up the heart valve he worked to fix. And he looked at me and just said, well, we're not fixing it. And give you 3 months to live. And walked out. It was pretty heartbreaking.
I've never gotten a huge high, right? I've never struggled with the use disorder. And I'd say that throughout the first 5 years of my career, I thought of those patients as bad people. I would come to the bedside, I would lack compassion. I would tell them, why are you using? You're gonna die. Do you know you're gonna die if you continue to do this? You know your abscess is preventable? And I really did not treat these patients with the same amount of respect, deference, and compassion that I did with other patients who I saw every single day.
Long before I heard the word stigma associated with OUD, I felt the stigma of OUD. We clearly have experienced it for my entire career of 35 years in emergency medicine. But as a parent of a child that suffered from opiate use disorder, I can tell you that I've had people come up to me and ask me where I failed as a parent.
So we live in a culture that teaches us to marginalize and dehumanize people who use substances, including people with opiate use disorder. And that is in the way we talk about substances from a very early age. We were told to talk about drug use as a moral issue, that you're doing something morally wrong if you use substances.
Even the uses of the term addict and how prevalent it is within the media, and how human beings as a whole, we're sensitive to language. And I think patients, when they hear healthcare providers use stigmatizing language, it really discourages that discussion of talking about their disease.
When I see people walk out of a room and refer to room 23 as a drug seeker, it hurts to my core because they've labeled them with a stigma that starts them down the entirely wrong pathway. My daughter was very hurt by any time that stigma got attached to her because she was very much engaged in trying to get back to her real life, and she was very vulnerable. So anytime someone slapped her down, she stayed down for a while.
I would hear often that there are people that are really sick that really need help here. Like, why are you taking up space? I have left the emergency room so many times after hearing so much more, just your kind of a feeling of worthlessness, that I had attempted suicide, and it's just those few little things that I didn't need that extra pile up. Things are hard, things are bad as they are.
When people are sitting in front of you because they are in so much pain from whatever their life circumstances have been, that they have turned to using a drug that they hate and they want to stop so desperately and they can't, trust and believe that they are absorbing every ounce of your energy in that room. They're very susceptible to everything that's going on. And I'll say, sort of really as a generalizable statement to most people who find themselves addicted, we're incredibly compassionate, incredibly sensitive people. And we feel a lot. And so it hurts a lot when people aren't willing to be kind, you know? and they can't see the human in us when we're sick and suffering.
I would have rather died than look at one more doctor and have one more doctor see me as somebody unimportant or threaten amputation or threaten, well, this is what you're gonna get. There's nothing you can do that I haven't done to myself over 1,000,000 times and asked myself 1,000,000 times over and berated myself. And so all of that is just my own internal calibration headed back at me. I feel every bit of that. And I think it's so important that we realize what it takes for a person to show up.
We don't seek treatment, I think is the most important thing. That's one of the reasons I didn't go to the hospital whenever I was running a fever for several weeks, and it turned out it was endocarditis. We don't seek treatment, and we just don't know where to go. We don't know what to do. We don't understand our own addiction. We don't understand why we're doing it.
130 people are dying a day. They're somebody's mother, father, sister, brother, spouse. We have this huge burden, we know it. We know there's treatment. We know what happens when we're inactive about it. So tell me why we aren't doing it. There's no reason, there's no logical reason. So then one has to step back and say, it's built on a lot of things like stigma.
From a professional perspective, especially when folks don't know that I'm recovered myself, the language that I hear amongst nursing staff, emergency room staff, clinical providers, therapists, it's incredibly stigmatizing, and patients don't hear that stuff. And that's coming out through our energy, that's coming out through our approach, and that's coming out as biases that we think aren't there or that no one can see.
Physicians are frustrated for several reasons. Number one, we rarely get the positive feedback. We don't get enough people that come in and hug us for starting them on the road to recovery. Unfortunately, every night we see the patient that comes in combative, or the same patient again that we haven't made any progress with, and it's frustrating. And out of frustration sometimes comes anger.
You go in there mad, the patient gets more upset, you have a relationship that's antagonistic, and at the end, there's the old saying that hating or being angry is like drinking poison and asking that the other person die. That's what you do in that relationship, is you're actually doing irreparable harm to that patient and to yourself. And you bring that anger out with you throughout the rest of your shift. And to tell you the truth, there's just a much better way.
And come back and talk to you about this anytime.
It won't be me necessarily, but you can, if things are not going well, your pain's not controlled, something's not right, come back and see us.
Okay.
I think the first thing would just be to check yourself at the door and kind of realize that you have these biases and that your life is way easier in most every way than theirs, and to try to be empathetic. I think if you can just start by removing some of the blame, because I think they have enough self-loathing and guilt surrounding their own addiction and the struggle that they've put their loved ones through and themselves through. There's plenty of guilt and blame already there, and you don't need to contribute to that. That's not your role.
When you learn to actually look at the person and see the person rather than their use disorder, when you are able to reinfuse passion into that relationship, and then you're able to offer that patient hope, whether that be with medication for addiction treatment, or whether that be giving them naloxone and saying, hey, this is going to keep you and your friends safe in case one of you overdoses. It's transformative.
There's a few things I can definitely do to also help you with the pain that you're feeling.
I'll tell you, these patients are so grateful when you actually bring that compassion to the bedside and treat them like human beings. And now I'll tell you, they're my favorite patient population. I have more therapeutic relationships with the patients that I get out of withdrawal than I do with a lot of other different patients. I try to sign up for these patients every time they're on the board because I know that I have a lot to offer them.
Do you have any medical problems I should know about? Diabetes?
I remember a nurse was coming into my room and just told me that she was rooting for me. And I will never forget that, is that I hadn't heard anybody was rooting for me in so long. I was so thankful to hear something like that.
I work with people that use drugs, and people constantly thank me for the kindness we offer, and we don't do that much. And it really makes me sad because we do so little, and people are so grateful, and they should not be as grateful as they are.
I think we need to recognize the power that we hold when we treat folks in these positions. I think we need to value that, and I think we need to understand that everything we say is going to have an impact. Recognize how important you are in that person's life and in this part of their trajectory. Be mindful about how you're engaging with them. And you have to think too, you're not the only provider that's come in contact with this person. This person has probably been to many providers just like you. How are you going to be any different? What are you going to say that's going to make the difference? And what are you going to say that's going to make that person remember you after they leave those doors? And I just want to stress that because I don't know that people know that they are playing that big of a role in someone's life.
All right, great. So we were going to break you guys out, but we're realizing we've got another breakout plan. So we want to just, if you guys could just shout it out. What did you see? What did that evoke? What stigmas did you recognize? Shout it out. I'll call on Lori. I know Lori. What did you see, Lori?
Well, I just saw a lot of, it hurt my heart.
Yes.
So for people to be treated like that, and I know a lot about this stuff. And so watching it is it's painful for me.
It is. I mean, just to hear that suffering and that when people are down, that we would not consciously, right, but that we would, because of the stigma we've been taught, that we might cause them more harm. But
it's the blame that's so, it's the blame.
Yeah. Yes, exactly. We still blame them and think they should stop. It's their fault. They got this disease in the first place and they should be able to stop it. Thanks, Lori. Anyone else? All right, so here's the good news. What we're going to do is talk to you about what we can do. One of the many things, but the simplest thing that we can do is pay attention to our language and how we are talking about our patient. We know that language plays a major role in shaping how people think and how they believe. And there's a great quote on the next page about how powerful words are. So this is from Otto Wall, and he said, words have power. They have the power to teach. They have the power to wound. They have the power to shape the way people think, the way people feel, and the way we act towards each other. So really, our words are so important. This is a study that was done at Harvard, their Recovery Research Institute, that was published in 2020. So what they did, and I can't remember the number right now, but it was a large study. They divided the participants in half. They gave one half, 516, Laura says, Lori says, in one half, and then the other half, they gave the exact same scenario. The only difference was in one scenario, it said, Brenda is a 33-year-old Caucasian female who is a substance abuser. She presents today, blah, 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 with the same exact everything, way she grew up, where she worked, her education, everything about her. Then at the other half, the only difference was, it says Brenda is a 32-year-old Caucasian female who has a substance use disorder. She presents today, blah, 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 blah. And so the results were, when they saw Brenda, I got you on my mind now, Lori. When they saw Brenda as a substance abuser, 41% thought she would benefit from treatment. 69% said no. 67 thought the substance abuser should be punished. Only 21% thought the person with a substance use disorder should be punished. 58% thought the person who was a substance abuser was a social threat, where only 42% thought the person with a substance use disorder was a social threat, and so on. So they wanted to blame them. So we want to really pay attention to not only the words that we are using, but the words we are hearing, being able to call people out, even if it's just in our mind. If you're reading a newspaper or an article on the internet and they're talking about, addicts, whatever, but they do use sensationalized language. So what we want to use is first person language. So here's some of the sensationalized languages, that just examples of some of them, crack babies, there's no such thing, right? Showing the opioid epidemic, fighting the demon, the skulls, just sensationalized. And here is our favorite one. We always have to make fun of this. They talk about weird orgies and wild parties with the drugs. And then we always ask, what's a weird orgy? Right? But anyway, so just paying attention to it. And then next, I think we've got some more words. So this is just why we want to use first person language, and especially in substance use, but in all ways, because a person is a person first. And behavior is something that can be changed. And when we put their illness first, it implies that they're not going on to be able to change. And using terms like addict, junkie, whatever, implies that someone is something instead of describing their behavior. So it's a barrier to care. It matters. If we want to nurture something, we call it a flower. If we want to kill it, we call it a weed. I wished I had come up with that. It's beautiful, but it's true. And next, I think you've got this, Tamara.
So we want to know and talk about where in the world do we go from here. So remember, it's because of stigma that some people do not seek treatment. They won't, some providers will not treat folks with SUDs. Some farm companies won't work toward developing new treatments for people with substance use disorders, which is something. We know that, Suboxone or buprenorphine products came out in 2002. And since that time, there really has not been a whole lot of anything developed. So the X script is something that you can use in your workplace with peers and even with patients, and it acts as a guide for you. So looking at the acknowledgement of just opening a dialogue about substance use disorders, and try to not criticize any misspoken words. Create a circumstance for reflection, so you can kind of ask questions out loud, like, how did we learn that, and why is it that we believe that anyway? You can share an article, ask permission to share knowledge about what you've learned, like share about what you learned here today, and support, encourage peers and patients to try new approaches. So an example of that would be if a patient says, yeah, all I am is a junkie, and you could restate it by saying, well, you are a person with a substance use disorder. So in summary, for doing this with peers and modeling this in other venues, so to speak, just get comfortable talking about substance use and discrimination, model appropriate language. We're going to talk about chart documentation, or Gina, I think you're going to take the chart documentation in just a second, because this will not only change what we do, but also change the environment, and it'll change how we do our work. It feels so much better to use person-centered language than the other. So the APA, talking about documentation, Gina, do you want to do this one?
I do. So in 2017, they said we should no longer use stigmatized language. The media, talking to the media because of the impact it has on individuals and policy. I'm sure not seeing it happen yet. They instruct that the word addicts should no longer be used as a noun, and to avoid using nouns like alcoholic, user, and abuser. Instructs to avoid words like abuse or problem in favor of the word use with the appropriate modifier such as risky, unhealthy. I love, that's my favorite term. I think people who haven't developed a substance use disorder yet really relate to and will listen to our the information we have about unhealthy drinking if we use terms like that. Misuse.
Thanks, Gina.
Mhm.
Thank you. So remember, conditions where biases are most likely to surface is when objectives or when judgments are subjective, when we're busy, distracted, when we feel threatened or insecure. So the next few slides, I'm going to just zip through these really quick. It's examples of language and the preferred language. So instead of saying addict, alcoholic, junkie, abuser, we want to use that first person language and say person with a substance use disorder. Instead of clean, when we're referring to recovery, we want to talk more medical terms and say, you know, being in remission, or our patient is in remission, partial, sustained remission, etc. So also when we talk about being clean or dirty when referring to urine, we have been assured that there is no dirt in urine. So we want to use words or references such as positive or negative for a substance, or we have a surprise in the urine, but not using the words clean or dirty. We're trying to get away from the words drug overdose because it implies responsibility or intention, and instead using drug poisoning, accidental overdose, etc. And what's interesting about this is that according to the CDC, we got about 86% of what they term drug poisoning deaths were unintentional. 8% were suicides, and there's really not precise determination of the real intent of about 6% of cases. We're also trying to get away from the term relapse and use return to use or recurrence because they're less demoralizing and they carry a greater hope. And then we're moving from saying medication-assisted treatment to medications for opioid use disorder, because the medications can be the treatment, whereas MAT suggests that that's a part of the support for the treatment. So I'm going to go through and give a little history and information on medications for opioid use disorder, starting with the history of opioids, been used throughout centuries, throughout decades, for various uses. And I'm just always fascinated by the fact that morphine is named after the Greek god of dreams. We had the hypodermic needle come on board for rapid delivery to the brain. And of course, surprising to me is that the majority becoming addicted were women because they were diagnosed with pain at a higher rate than men. But in the early 1900s, tens of thousands of people were addicted to morphine. And by 1914, in response to street heroin and morphine dependence, doctors and patients were advised to avoid opiates. Okay, so you guys were right back where we were, 108 years ago. We are right back where we were. This continued into about the 1990s, and medical community was starting to wonder, well, how in the heck are we going to treat pain? So with a suggestion and push from the VA, in 1999, pain was recognized as the fifth vital sign, and I'm sure that you all recognize the Wong-Baker faces. This stat is staggering to me. OxyContin prescriptions increased from 670,000 to 6.2 million doses in that period of time, and the Wong-Baker validity is so wrong. It either under or overestimates the pain. So it is actually not a useful tool. In 2007, we know that Purdue Pharma pleaded guilty to federal charges related to misbranding. They overstated the benefits and understated the risks, and we have seen our deaths just drastically increase. We know that synthetic opioids came on the scene in 2013, including fentanyl. This caused over 20,000 additional drug deaths. And then in 2019, we had the severity of the public health issue named, and we had more funding thrown at this epidemic. So we have I see I left it off of this slide. It's the Data 2000 enabled providers, MDs and DOs, to be able to prescribe buprenorphine products. Buprenorphine was approved by the FDA in 2002. The CARE Act, to expand access to services, expanded that prescribing ability to physician assistants and nurse practitioners. We've got the national emergency in 2017. And then by the time we hit 2021, we see opioid poisoning deaths top 100,000 a year. What we know today is, as of, within about a month ago, we hit 108,000 for 2002. So these are just a few of the landmarks time marks that we see along the way. And we know that we've lost a lot of people that we know publicly to accidental overdose or opioid poisonings. I'm sure many of you have seen this picture before. This is an example of what it would take for an average death to occur by ingestion. You can see where heroin is this much, and fentanyl not too much at all compared to carfentanil that would just take one tiny little speck in order to produce death if taken. So we know the death pill, what's being referred to as the death pill, that fentanyl is disguised as other drugs. It is in most everything: cocaine, hydrocodone, Xanax, sprinkled or mixed in with marijuana. Right now in the state of Montana, as well as 38 or so other states, to be in possession of fentanyl test strips is considered a misdemeanor, and one can get arrested for that. It will be overturned in this upcoming legislature, as it is expected to in other states as well. Some bodies say, why even use a fentanyl test strip, because fentanyl's in everything now. And the response to that is it can absolutely serve as a deterrent to either not use as much as intended or perhaps pick something else. This is our Montana OD map. So this is a national database that receives information from all of the expected places you would think. So emergency medical services, law enforcement, coroner's offices, et cetera. And this is what Montana looks like from January 1st through 2020 through October, the last day of last month. We've had total suspected overdoses at 2,047. Of those, the fatalities were at about 390, and naloxone was administered in 718 of those. You can see that this follows the normal and expected pathways of, here is Highway 93. Here going on a curve down and around is Highway 90. We've got 15 going up Center State. So this is what we look like. If any of you are interested in your OD data for your county, just shoot me an email. I'm happy to get screenshots for you. So where do we go from here? We know, thank goodness, that this epidemic is different because we do have the medications to treat this illness. What we have seen and experienced is that there is a lot of partnering and more disciplines are coming together to address this epidemic, which is really awesome. So a lot of people have asked, why in the world are we doing this anyway? So when we look at national stats, we know that 2.5 million Americans are addicted to opioids. In 1999, we had 0.3 per 100,000 overdose deaths were attributed to opioids. 2019, that went up to 11.4. This is nearly a 520% increase from 1999 to 2019. Holy smoke, that's a lot. Cost to society, I couldn't get the updated figure on this, but I can say, I think with in a reasonable fashion, that this has doubled or even tripled since 2017. And 71.8 to 80% of overdose deaths do involve opioids. So let's bring it home to Montana. 45, nearly 46% of our overdose deaths involve opioids, meaning 3 to 4 of every 100,000 die from an opioid overdose. About 0.15% of hospital births have cases of NOWs. And this one just kind of blew me away. Enough prescriptions are written for nearly 51% of our residents to have a prescription for an opioid. So we're not quite out of the woods yet. We know that treating opioid use disorders with medications is 5 to 10 times % more effective than treating without. There's fewer medical interventions that have such effectiveness. So this is a letter that was shared with me from my coworker, Dr. Sharon Mulvihill, who is one of our providers out of Riverstone over in Billings. Okay. Just giving you a minute to read it. And you can see how much this has changed this person's life. To be on medication, getting the assistance that she needs is really helping to save her life, has saved her life. And she is, again, functioning and stable. So pharmacology, I'm a social worker, and so this is absolutely not my bailiwick. We know that we have agonists and antagonists, and agonists fill up the what do you call that, Gina? It just escaped my head. The receptor, it's right there on the slide. And then we have an antagonist. We know that buprenorphine, Suboxone is an agonist, antagonist. The bottom line is it averts cravings. So cravings go away. And that's really one of the #1 reasons that people will resume use, is to avoid withdrawal and cravings. It's very uncomfortable. It feels like you've got a bad case of the flu. For quite some time. And then if one happens to use an opioid, there is no euphoria achieved. We have available, and certainly Mandy, I'm happy to get these to you, some really nice cards that kind of, describe the different kinds of medications that are available for opioid use disorder. So just really quickly, we're going to go through the myths here that we hear a lot about with medications, that it's trading one addiction for another. And in fact, it doesn't create a high. And what happens is they're going to eliminate the use of those opioid medications in order to allow them to develop some new skills or different skills that's required for remaining abstinent. It's hard to learn anything when you just feel terrible all the time. So that's one thing that MOUD does. Another myth is that it's only for short-term treatment. Bottom line, a patient needs to be on a medication for as long as that medication is effective. For others, it can be a year, a lifetime, 6 months, 5 years. The time that a patient usually considers coming off of a medication for opioid use disorder is when their lives are at the relative best that they can get. And we've worked with actually a lot of patients who have tried to taper off and who have tapered off and just still did not feel right. And so remain on a low dose, meaning like 2 milligrams, and they do just fine. Another myth is that it increases overdose risk. In fact, we know this is the most effective intervention, and this actually prevents the risk of overdose. Another myth, it only delays and disrupts true recovery. We know that it actually assists recovery by improving their quality of life, functioning, and the ability to handle everyday events. Another myth is that pregnant women can't receive MOUD. We know that as per the American College of OBGYNs, that MOUD is the recommended treatment for those who are pregnant. And cold turkey, Gina and I were trying to figure out where the heck this term came from. We can't really get an answer yet, but cold turkey is better than MOUD. But what we know is that it also does not address cravings. And as I mentioned earlier, you know, the thing that really drives a return to use are cravings and withdrawal symptoms. So the reasons that we get it wrong is we think of substance use disorders differently from other diseases. And what we know is this is a chronic illness that requires lifelong management. We have unconscious bias that's unaddressed, possibly the lack of empathy, or an inability to understand the life of a person with an opioid use disorder. And oftentimes this relates to our own negative experiences, either with ourselves or somebody in our lives, or you know, in our environment. We want to apply faulty behavioral theory. We want to punish instead of support. We could misinterpret the literature, and sometimes we're not using the appropriate treatment goals. So when we talk about harm reduction, really the goal is to make people's lives better, regardless of their choice to take or not take substances. It's radical empathy, and it's recognizing that their lives have value. Low threshold care is one of the key elements. And what that means is, you know, same day, if somebody walks in and they are needing assistance for an opioid use disorder, if they meet criteria, get them started immediately on medications for opioid use disorder. We want to remember to not let perfection be the enemy of the good. So what we want to do, if you guys take a little picture of this with your phones, get your phones out and take a picture. We're going to take about 5 minutes and go into a breakout, and we would like for you guys to answer these questions. So what do you think of or about when you hear the term harm reduction? What does it evoke in you? Something, nothing, anything at all? And how would you feel about having an overdose prevention site in your neighborhood? So I'm going to get you guys into breakouts, and we're going to take just a few minutes. There we go. And talk about that. Am I able to put them into groups?
I have them all ready to go, Tamara, so I can open them up.
All right, let's hit it, and let's take about 3 or 4 minutes. And then we'll bring you back and we'll do a report out.
Sounds good.
Okay. Okay. All right. So Gina, I don't know if you were taking a break with the dogs, but I did the language really quick because we were running out of time. So how do you think, how are we doing, Mandy? We doing,
Yeah, you guys are doing great. Yes, totally. And I've actually received a couple of messages already that people are enjoying the content. So you guys are doing great.
Oh, I am so glad. Okay, good. So when we come back, we're just going to be, we will finish up harm reduction and just talk about treatment goals.
Okay.
And then I'll show them the map, kind of where we're at in the state with providers, and that's it. And then just have questions. So
cool.
Should get us to like maybe 5 till. So we should have some time for questions.
Okay, perfect. So I don't know if you guys need to keep any records or anything, but there were 26 students total that were on today. So
Oh, that is awesome. Okay, thank you for that. I do keep track. Write that down. Oh, and plus yourself. You counting yourself in that?
I'm not. So 27 if you count me.
Oh, that's perfect.
Yeah. And then I do always post the recording for folks too. So it can easily get you a count of the number. It's we just put it on a private YouTube channel so we can keep track of how many views it gets. So if that's ever interesting to you, we can let you know. But we give the students an opportunity who couldn't make it tonight to watch it later.
Okay, and did I send you this PowerPoint?
No.
I may not have, so I'm going to do that right now.
Cool.
Okay, why don't we go ahead and give them the 1-minute warning?
Okay.
And then Gina, do you want to do a kind of elicit responses on this or?
Sure. Did you have them identify a spokesperson or?
Oh, I didn't.
Okay.
I did not.
We'll just call on people.
This should be everyone, Gina.
All right. All right. So let's do it. So who we have, like, Mandy, who was in group number 1?
Oh man. I have to pull it back up. I had Amy, Bryn, Ellie, Leah, and Shannon.
All right. So somebody from that group, what did you guys talk about?
Uh-oh.
Uh-oh. Silence. So what do you think of? So when you hear the term harm reduction, because some of us, I don't know how many of you have come from this world of where it was abstinence only, right? No harm reduction. Mallory, I see you're shaking your head. Did you want to, were you in group number 1? Oh, you can just go ahead though.
Yeah, I guess I don't even think I realized how growing up in the DARE era impacted me. And so when I was first exposed to the idea of harm reduction, I just thought, oh my gosh, absolutely not. Like, this is so counterintuitive to everything I know. But since first learning about what it means, and just, I think what I want my own personal approach to care to be, I just think there's no better way to meet folks exactly where they're at, and reinforce the idea that whether they're using or not, we value and care for them just the same.
Oh, I love that, Mallory. Thank you. And do you find it interesting that, especially now that you started your studies, that we would never not think of harm reduction with any other chronic illness, right? Of course, we want their blood pressure to go from, we want it to go down. We don't want it to be perfect or you can never come back here again. That's great. How about you, Shannon? Anybody shaking their head, boy, you're going to get called on.
I resonate with what Mallory shared, and also what it brings up for me is this premise of autonomy, in that folks have the ability to make decisions, and us as healthcare providers can walk alongside and help offer choices.
I love that. I love that. We are not the boss, right? And I think that's one of the foundations of motivational interviewing, is that, we may know a lot about the illness, but we don't know a lot about them. They know a lot about them and what they can do. Okay, how about you, Leanne? I see a nod.
Oh, just I've actually really liked what Lori had to say in our group about just any efforts to keep your patient alive is a good effort. So, for example, if you have a patient who's shooting up meth every day and then now all of a sudden they're addicted to weed, well, that's harm reduction. If they're no longer shooting up meth,
right.
And we think about things that way in the context of like normal disease, but we don't necessarily always think about it that way in addiction. So
yeah. And Leanne, what do you think it is? What do you think is the reason that we don't?
I don't know. I don't know. Yeah, I guess just comes down to all that stigma we were talking about earlier.
That's what I think. Yeah, but I would be interested if there's something else anybody thinks. Did you have something else you wanted to say?
Oh no, but I mean, I think just knowing a lot of people like in my life personally, I think there has to be some level of just fear, and because I think a lot of the people that I've known who have succumbed, or I guess I should say have died because of their addictions, they weren't all that different from the rest of us. And so I think just like thinking about that, it's like something we don't want to see in ourselves, and so we push it down as inferior, like, oh, it couldn't happen to me.
Right. Yeah, us and them. Somebody said something. Oh, we're just moving on. All right. Thank you, guys.
That's awesome. And thank you for, thanks for sharing. Thanks for facilitating that, Gina. So yeah, harm reduction, it's not a new term. It's developed during the AIDS epidemic. And as you guys just said, it applies to the treatment of all chronic diseases. So our traditional harm reduction mechanisms are safe injection practices, naloxone rescue kits, syringe and needle exchange, overdose prevention sites, and these all address healthcare maintenance. So when we talk about treatment goals for this population, and if we're looking at harm reduction, it's variable based on their degree of ambivalence. And for those of you familiar with the stages of change, it's going to be different for each identified problem. So it's going to work for some problems. You got to have a more comprehensive approach for others. But the bottom line is long-term engagement, or that continuous, compassionate, open door. Whether it takes days, weeks, months, or years, that is what is going to be the most effective in facilitating success. Excuse me. So the continuum looks like this. On the left, it's minimization of harms from ongoing use, all the way over to sustained recovery with abstinence from all substances. So when you think about your team, when you're working with patients as a team or as an individual, you got to think about what you can accept. So with harm reduction, it's less engagement, less compliance, less adherence, and obviously use of other substances. Over on the other side, it's more engagement. There's broad social support. Patients are compliant, committed, and motivated. Growth and stability is evident across all domains, and obviously their baseline functioning. Lapses or return to use are results of mistakes and not failures. They create learning opportunities and they create enhanced recovery. So when you find yourself in a situation where you're on an integrated behavioral health care team, these are some things that you guys need to consider as a team. It's like, what can you tolerate? What will work? And what can you do? So in Montana, this is what we look like in terms of actual waived providers. In 2017, right before we started this work, we had 20. And then we started, spreading the word and doing trainings. And in 2020, we had 178. And then at last count, just a few months ago, we had 494. You can see our highest counties, with the most providers are Missoula and Yellowstone. And those areas where there are, it's white is, we don't have anyone in that county, but there's some telehealth coverage. So of course we are hoping to get every county up to at least that kind of turquoisey, 11 to 25 color. So that's what we look like in Montana. So in wrapping this up, before we go into questions and discussion, here is what we seek. This is from Father Greg Boyle, Tattoos on the Heart, the Power of Boundless Compassion. Here is what we seek, a compassion that can stand in awe at what people have to carry rather than stand in judgment about how they carry it. Just love that quote. So we just want to really thank you guys for having us and open it up for more questions and discussion. Anything you guys want to talk about, we are game.
And know that we have an addiction specialist here with us today, Dr. Knotts. Pretty special.
Hi, I was wondering if it'd be possible to get a copy of the slides. I thought this was like really useful information, and just going through it pretty fast. I was trying to take notes and wasn't able to get some of the information I wanted.
Yep, Mandy's got it.
Yeah, I have them, and I have everyone down who attended today. So I will just probably sometime later this week, I can send that all to you so you have it. And this has also been recorded and will go up on the Canvas platform in case you want to watch it again. But yeah, happy to get the slides to you.
That'd be awesome. And then I had a quick question about why the Wong-Baker is not a very appropriate scale to use for people with opioid use disorder.
It's not valid for measuring pain. Dan, can you give a few comments on that? Is Dan still with us?
Oh, I think we lost Dan. Oh, no, he's here.
I'm here.
Oh, there he is. There he is.
I am here. No, what was happening with that scale is that the providers were responding to the scores by either, and using that to guide opioid prescribing. And then we became aware that what really is important to a person may be experiencing fairly significant pain and may rate themselves at a 5 or a 6 or maybe even a 7. But then when you ask them, and this study has been done, by the way, and you ask them, are you able to tolerate your pain? And they say, yeah, I'm perfectly fine. It's irritating, but I still can get my work done. I can go and work and so on. That is not a person that needs opioids or more opioids. And so that we became aware of that discrepancy. So there is a movement afoot to get away from those faces. But I think, still use them, but add to that. Well, can you tolerate your pain? and frankly, and much of the time, and frankly, in Montana, especially in rural areas, people are fairly well informed and they're fairly adverse to actually taking opioids, and they will be fairly comfortable with not receiving opioid pain medication.
Thanks. Thanks.
So, Dr. Knotts, along those same lines, we still are using pain as the fifth vital sign, especially in acute care. I'm wondering, is that something we should still be doing? I've seen some conflicting evidence that perhaps that makes people rate their pain higher, receive more opioid pain medication. How do you feel about that?
Right. That's a tough one. I think we still need to assess pain, especially, obviously. I'm not saying this is not time to throw the baby out with the bathwater, but I think we have to do a better job at doing it, looking at, well, is your level of pain tolerable, looking at other parameters that are associated with pain, whether it's anxiety, whether it's tachycardia, hypertension, etc., and treat accordingly. But I think the tendency, especially in intensive care settings, I think is if the patient's aware enough to score himself, that there is a real risk of over-treatment. So, and I think that this is an area that frankly has not been well researched. The tolerability assessment is relatively recent, and I've not seen anything similar to that regarding getting at least a subjective response from the patient.
Thanks. I see we're like at 1 minute till. Is there any other questions or comments? Yeah, Mallory?
I have one more. I'm just curious about what harm reduction is looking like statewide. I know that's a big question, but if you guys have any awareness of communities or FQHCs or any organizations who are doing good work in that arena.
Mm-hmm. We do have, there's several needle exchanges that I know of in the state. There's one in Kalispell, here in Missoula, Billings, I believe Bozeman. And some are in FQs, some are in outside agencies, some are in a more public health setting. So I don't have all the specifics on that. And then of course we have available the naloxone rescue kits that are available at no charge from the state. That's happening. Of course, we don't have clean injection sites right now. So those are the two in most use right now in Montana.
Okay, just a comment also. We don't want to necessarily put ourselves in a box around harm reduction programs. Tamara's alluded to the ones that exist, but it should be part of our practice in when we're treating patients with substance use disorders, and we have an awareness that they're using IV, that we discuss safe injection techniques and so on, and talk about signs and symptoms of infection, appropriate screening for hepatitis and other bloodborne illnesses. So, it's that each time and that's the key. And I think one of the slides address this. When we work with patients just like we work with a person with diabetes or hypertension or coronary artery disease, we're working with the whole patient. That patient has neglected their health care because of stigma. They're afraid to go to doctors. They're afraid that we're going to be the way they're going to be treated and so on. This is an opportunity to provide good healthcare maintenance, vaccinations, all the usual stuff that maintains our health.
Yeah, thanks, Dan. Okay, well, thank you, Mandy, so much for having us. You've got the PowerPoint. If you need anything else, just let us know.
Yeah, that's everything. So thank you all so much for being here. I did email off the slides already, and your 1.5 hours have already been put into the Canvas platform as well. So you don't need to do that either. But otherwise, thank you so much to Tamara, Dan, and Gina for their time this evening. I don't know if you have a few extra minutes, if there's any other questions, people might be able to hang on. But